Good afternoon and welcome to the Hudson Institute. My name is Husain Haqqani and I'm the Director for South and Central Asia here at the Hudson Institute. I would like to welcome all of you for what we hope will be an interesting and exciting conference on innovation and healthcare in India. Hudson, of course, is a think tank that has existed since the 1960s. We basically try to examine issues from the point of view of looking at trends as well as looking at future prospects. We believe in a strong America that leads the world. We believe in free markets, but at the same time, we look for policy options that can advance bigger goals in various parts of the country. Hudson launched the India and Globalization Initiative in March 2014, with healthcare and innovation among 5 areas of our focus. Our annual reports every summer look at issues of health, innovation, defense, economic reforms, and trade in India. We firmly believe that India is an emerging global power, and we want the United States and the rest of the world to engage as effective partners in India's rise. Our analysis of India's trends and projections reflect our hopes, our expectations, and our aspirations. When we critique policies and propose changes, we do so as friends. India, a country of 1.2 billion people, has a GDP of $7.9 trillion on PPP basis, and it has one of the fastest growing economies in the world. Yet it only spends 4.7% of its GDP on healthcare. 4.7. In comparison, Brazil and South Africa spend 8.3 and 8.8, which is almost twice the percentage as a proportion of GDP of India. Even Nepal, which is much smaller and has a much smaller GDP, spends 5.8% of its GDP on healthcare. India's spending on healthcare is less than half the average for OECD countries, which is 9.3%. The United States spends 16.9% of its GDP on health. This low government spending means India, now in addition to low spending as a proportion of GDP, India also has much less government spending on healthcare. It has one of the highest out-of-pocket spending rate globally. According to World Health Organization, only 33% of Indian healthcare expenditure came from government resources, while the remaining of the remaining private spending, 86% was out-of-pocket. India has only 1 bed for 1,050 patients in contrast to 1 bed for 85 patients in Japan and 1 for 350 in the United States. India has 0.7 doctors and 1.5 nurses per 1,000 people. That is drastically lower than the World Health Organization average of 2.5 doctors and nurses per 1,000 people. India ranks 80th. Now, I know I'm overwhelming you with statistics, but this is just to set the stage. We will listen to our experts carefully. But before we get to them, let's see what is the nature of the beast. So let me describe the elephant before we start dealing with its specific parts as the trunk or its various other components. So India ranks 80th out of 117 countries in the 2015 Global Hunger Index. And Sri Lanka and Bangladesh, which are neighbors of India, rank much higher. There has been some improvement in India's health indicators in the last few years with a lowering of infant and maternal mortality rates. India's life expectancy of 66, while improving significantly, still ranks 14 years lower than the OECD average of 80. Population having access to clean water now stands at almost 90%, which is a major improvement. However, population with access to improved sanitation stands at less than 40% of the total. Now, Prime Minister Modi, of course, was elected 2 years ago with the expectation that he will drastically change India's direction away from the socialist policies of the preceding years towards a more market-oriented approach and one that will attract a lot of private investment, including foreign direct investment. The Modi government announced a national health policy which set as its goal the provision of modern health services to all Indians. But it is not something that the Indian government can do it on its own, and the Modi government is aware of that. If every Indian is to be provided healthcare, the government will need to support the private sector, both domestic and foreign, to bolster India's key health indicators with significant improvements in infrastructure, financing, and research and development. And none of those things would be possible without significant changes in India's policy framework. For those of you who are interested in learning more about India's healthcare and what we think India needs to do to improve its indicators, we are happy to announce the launch today of our report entitled India's Health Under Modi, Agenda for the Next 2 Years. It's a very important report that we have prepared. I think copies should be available as you exit. It's an effort by us and various experts, both inside Hudson and outside, with whose help we have tried to look into the future, short-term future of the next 2 years and say, what are the concrete steps India could take to try and improve on its current indicators and get on track for the major changes that Prime Minister Modi promised but is having difficulty in delivering in full. This report reviews the current state of healthcare in India, the initiatives of the Modi government, and the challenges and opportunities in the health sector over the next few years. I hope that you will pick a copy and will look at it and examine its findings. We are happy to have feedback. I'm sure there are people in this room. The great thing about democracies is that everybody has an opinion. In addition to having, in fact, everybody has the right to multiple opinions, even though each one of us has only one vote. And so we would be very happy to have feedback, especially from those who are connected to this sector themselves. Now let me introduce the first two panelists for our discussion today. The first panel will provide an overview of innovation and healthcare in the Indian context. The second panel will then move forward and look at specific initiatives of the private sector within this rubric. So for our first panel, I am very grateful to Dr. Amit Kapoor and Dr. Ranjana Smetacek, who are both experts in their respective fields. Dr. Amit Kapoor, to my immediate left, is President and CEO of the Indian Council on Competitiveness and also Honorary Chairman at the Institute for Competitiveness in India. He sits on the boards of competitiveness initiatives in Mexico, the Netherlands, and France. I would like Dr. Kapoor to begin by introducing to our audience what the Competitiveness Institute does as well. It would be useful. Now, Dr. Ranjana Smetacek, who's sitting to the left of Dr. Kapoor, which is not necessarily a reflection of her political opinions, is former Director General of the Organization of Pharmaceutical Producers of India and is currently a consultant here in Washington, D.C. Prior to that, she was with Monsanto Industries and was Director of Global Biotech Acceptance and worked on projects in Europe, Africa, and South America. I would like Dr. Kapoor to go first, 10-minute introductory presentation, and then we go to Dr. Smetacek, and then after that, we open it for a robust discussion. So let's begin, Dr. Kapoor. Thank you very much.
Thank you, Ambassador. It's absolutely a pleasure to be here. In fact, as Institute for Competitiveness, we are a think tank, which is an affiliate of the Institute for Strategy and Competitiveness at Harvard. And we have a fairly broad program on research pertaining to urban areas and what I call cities and states and so on and so forth. And we focus on areas like healthcare and internet and I would rather say like automotives and etc. But having said that, let me just quickly dive into what I really see as healthcare innovation ecosystem in India. If we look at the numbers that Ambassador was sharing, These are some very interesting numbers, but we have to dig deeper in terms of like how India is performing at the various levels. In fact, India, one, cannot be looked at as a singular animal. It has to be looked at as an animal which has different parts. It's a different set of states which actually come together. And we see huge levels of variation that actually exist within the level of states itself. But if you really look at some set of numbers, India actually, when you talk about hunger index and so on and so forth, there are some other numbers which actually give a startling picture about the reality that we face. We are ranked number 98 on the Social Progress Index, which is more a thing wherein we are saying that you have to look at things beyond GDP and so on and so forth, and health being one of the biggest burdens. If you really look at other set of numbers in terms of how sanitation is actually having an impact, of course, the whole Swachh Bharat Abhiyan, which is a great initiative, and I think it is imperative that India needs to focus on it. But then there was this earthquake that actually happened in Nepal, and wherein about 7,000 people died. But if you really look at back home in India, you find something very startling, that close to about 7,000 kids die every week because of diarrhea. And that is actually a sanitation issue or a healthcare issue itself. Go deeper into the level of availability of doctors to such things. There are close to about 80% of the doctors cater to just about 20% of the people in the country. So that means there is a severe issue in terms of availability of doctors, availability of talent, and so on and so forth. But beyond that as well, if you really look at it, the issues of healthcare access and issues of availability of healthcare are not only driven by what you would call as the industry per se, or the market distortions, but it is also driven by huge infrastructural bottlenecks. It's a question of access that we actually have to understand. And when I say access, it's about access because of travel. To a certain extent, if you're actually living in a city, it can take you up to about 2 hours to get to a hospital. If there is a certain incident or an emergency incident that actually happens, could take you up to 2 hours. And in villages, it can take you up to about 6 hours on an average. If you're living in Himachal Pradesh or some places in Ladakh, it can take you multiple number of hours. So if you are actually having a cardiac incident, the prognosis could be that you're going to be dead by the time you actually get care. So what we are really saying here is that India has a very different reality on the ground level in terms of like how it has to be managed. And so if we really have to manage this, how do we really look at it? We have to look at innovation from a perspective of multiple sets of areas. So there are various pillars that we would actually have to touch on. And those pillars do not necessarily mean just government. It has to come from the private sector. It has to come from the patient care groups or whatever. To begin with, in fact, the first thing that we have to do is really look at spends on R&D itself. There was some number in terms of like healthcare that was actually being talked about. Like India just spends about close to 4% of its GDP on health. But there's another figure which is absolutely combinatorial onto this. Like if you really combine it, you understand that there is a lacuna that exists on innovation ecosystem. We just spend close to about 0.8% of our GDP on innovation or R&D activities. If that's the number, that means we are just not focusing on innovation per se. If you really look at the whole performance of India in terms of like how it is performing on patenting behavior, we are one of the smallest in the world. So why does it, and on a per capita basis, it actually becomes fairly abysmal. What do we do to really get this right? Can we actually look at the ecosystem in terms of how the educational institutions work? I think we do appreciate a lot of institutions that actually exist there, but then they are appreciated because of the quality of students that they get in, but you're not really they cannot be appreciated because of the quality of output or research that they actually give. In fact, from my point of view, and I think this is also going live, so a lot of people will hate me for saying it, but then I always say that IITs or even the Indian Institute of Sciences or whatever, they could actually be touted as non-performing assets of the country. And when I say non-performing assets, it's because the output that you actually see in terms of research is absolutely abysmal. The numbers, if you look at the numbers in terms of like publications and whatever, I think then we can actually say the reason for this non-performing asset is its faculty who's absolutely non-performing, does not contribute, does not create what you would call as enterprises and so on and so forth. So within the research ecosystem, there is a severe lacuna that exists. So how do we really create policy that we actually push out this research ecosystem? The second thing that we have to really look at is how do we really push innovative business models to this arena. In fact, the next big thing that has to happen in India is about innovation in the business models or innovation in processes. Today, India is definitively like what is happening within the West. It cannot get replicated in India. You have to find solutions for India. You have to find solutions in terms of really saying that what is it that I can do for a low resource setting. India is clearly a low resource setting country. So you create models for that. In fact, there are examples after examples as to how that has actually happened. I think if you really look at the complete set of industry, there is a severe focus on the pharmaceutical industry without realizing that you have to focus on care delivery as well. If you're not focusing on care delivery, you are actually going to get things wrong. So how do you actually get that care delivery process right? This is where you'll have to create delivery models which are unique and different. Say an example for one example which I feel is one of the finest in the country is Narayana Healthcare. And if you really look at it from a brutal economic perspective, how is Narayana Healthcare able to give the care that it is able to give at such a price? It is because of asset utilization. So when you talk about asset utilization, how they're actually giving healthcare in the night between those God-forsaken hours from 10 o'clock in the night to 5 o'clock in the morning, they're able to utilize that asset or diagnostic equipment to really give something very interesting. So we have to look at those kind of models. Or when you talk about Vatsalya as an enterprise, which looks at tier 3 cities and says that I'm actually going to build hospitals and cater to a certain level of disease segments and then pushes it out. So when you're operating in tier 3 cities, it is actually talking about prenatal, postnatal care. It is actually talking about diabetes. It is talking about renal disease and so on and so forth. So they are looking at some very specific disease segments. Having said that, well, what India needs to do in terms of like when you're talking about innovation in the system, and when I say it's a delivery process, you have to look deeper in terms of saying as to how the disease pattern is going to change. I think a lot of times we are just focusing on a certain set of disease patterns, which could be archaic. We are looking at some archaic numbers where there is, and the government actually works in a very slow pace. And this is where, when I say innovation is required, you need innovation at the level of bureaucracy as well. I think India suffers from the most defining bureaucratic burden in the world. And how do we change that? In fact, I say the last remaining relic of the Raj, or what was left of the British, is actually the bureaucracy. And how do we dismantle or how do we change it? In fact, there could be a situation where bureaucracy hates this statement, but the question is, they are actually the biggest lag in the system because and there is, of course, like when you talk about market-based solutions, you have to find a solution that you train these leftists, what I call as the bureaucratic people, because they're trained as control people. They're not trained as enabling people. So because the British trained them as control mechanism people or whatever, and we are just training them in the same way. So how do I innovate on the bureaucratic practices and change that model? If I don't change the bureaucracy, because it becomes a governance issue as well at that level. So that's the step that we have to take over a period of time. Moving ahead, I think, so when we talk about industry in terms of like how business models can actually happen, or how institutions can be taken care of, or how academics look at it. But the third thing that we really have, or one of the bigger things, or one of the pillars that we have to look at, is how do we strengthen the IP regime? I think there is an undue debate that actually happens in India, and wrongfully so, that focuses on that you have to have open source or whatever, and you just try to mix a lot of things. The question is that if you do not have a very strong IP regime, innovation is not going to happen because you're not able to protect yourself. Because IP is one of the biggest things that drives competitive advantage for enterprises. If I'm not driving that competitive advantage, or if I'm not able to create a competitive advantage, if I'm not able to protect it, why should an enterprise come in and give you the best level of care to the best level of medicines, or so on and so forth? So strengthening the IP regime is going to be very, very important for the future. If we don't do that, it's actually going to be one of the killer aspects. And having said this, there is one very big issue that we have to look at from an innovation perspective and competitiveness perspective, and that is about trust and competitiveness. I think there is a severe lack of trust that actually happens within different set of actors within the system. And if that trust is lacking, so how do we take policy action that trust actually is enabled for enterprises to actually do well or collaborate and things? If I'm able to create clusters within the US, or if you've seen clusters within the United States in terms of like how pharmaceutical industry or how healthcare industry is actually done or created those clusters, like from New York to Boston, some of the most amazing enterprises actually exist, or research enterprises exist in this area. So how do we create those set of systems there? So it is actually dependent on trust. So trust is the element which needs to be put in. And how can we do that? We can actually do that through IP and so on and so forth. So if you really look at the whole paradigm, we have to look at steps from policy, wherein we look at policy in terms of saying that push the R&D spends, look at systems or mechanisms where this trust happens. Third is that you have to understand that you have to look at innovation from a state level perspective. It cannot be looked at a country level perspective, because states will have to create the ecosystems for themselves itself. In fact, some set of numbers here. States which are doing exceedingly well in India, we know definitively that you have Maharashtra, Tamil Nadu, Gujarat, which do exceedingly well. And these are the same set of places where innovation is also the highest, the entrepreneurial activity is also the highest, and this is where the educational institutions also perform the highest. Just to add on to this point, if you really look at the emergence of places like Bangalore, Hyderabad, and Chennai, and three distinct states, that is Karnataka, Tamil Nadu, and Andhra, these three institutions, or these three states, actually happened because of a very strong educational ecosystem that got created. And that is where a lot of talent actually became available. So how do we really look at it? And having said it, so there are states outside this 3 or 4 states that we are talking about where performance of educational institutions or nationally ranked institutions is also missing. So we need to set this process right, focus on educational institutions, collaborate between the industry and the academia, and try to do something around it. If we don't do it, then I think we'll still be talking about the same set of things in the next 10 years as well. And that's some initial set of remarks from my side.
Thank you very much. I mean, there's a lot in that for us to digest, and I'm going to try and see if I can use my summarizing skills honed over a long period of time for the audience. You know, most important, you emphasized innovation and how India actually needs to get into that. You linked it to the IP regime, but at the same time, you made the point that innovation may be better handled at the state level than the federal level. However, that raises a question, and you can ponder over it when we come back. The IP regime is essentially a central regime. It's a federal regime. And so how would states be able to innovate without a significant willingness of the federal government to change the intellectual property regime? The second point you made, which I thought made a lot of sense, was that the pharmaceutical sector as well as the care delivery sector both need to be attended to simultaneously in terms of how they adapt to India. We can have a discussion on all of that as well. I'm sure there are people in the audience who may have questions and issues on the pharmaceutical side. You gave a few examples, few good examples on the care delivery side about, for example, innovative ideas that, if you have diagnostic equipment, this, that, etc., invert the usage, nighttime usage. If somebody is willing to go and have their MRI in the middle of the night rather than in the day, they can do it more cheaply, etc. Great ideas, some of which probably may actually make sense beyond India for people to think about and may have come on. Then comes the question of the bureaucracy. So that's the third point I think you've made. I think in the discussion, and there are people here, I see faces who have dealt with Indian bureaucracy and have lived and have survived that experience, have lived to tell the tale. How? Huh? That still shows in our face. And how do you change? I understand that it needs to be re-educated, but 70 years. Several generations now, 3 generations at least, of bureaucrats in terms of age clusters, those trained by the British, those trained like the British, and those trained by those who were trained by
only like the British.
Yeah. So how do you change that? We would be very happy. We have people in the audience who might consider assisting and helping us do it. We would be very happy to go and try. We're already considering a program where we can actually get new generation Indian members of parliaments to think differently than the old generation politicians. Could we do something like that with the bureaucrats? Would that make sense? It may need a lot more money than is available, but the US government spends a lot of money, for example, on exposing Indian public personalities to America and culture-wise. Should that be directed towards making them think differently than in a very structured socialist manner? So those are questions that I'm leaving for you for the second round after we've already heard from Dr. Ranjana Smetacek. Now, I know that you didn't deliberately set us out to have difficulty pronouncing your last name, but I hope I passed the test. And it would be a pleasure to hear from you, Ranjana, on the more specific ideas that you have for getting us going.
Thank you, Ambassador Haqqani. To begin with, I should state I'm not doctor, so thank you for that elevation, but I have not got a doctorate. So I will try to add to what Ambassador Haqqani, what Dr. Kapoor have said, and be careful also not to repeat some of those things which are also in my notes. In my view, these are two separate conversations: access to healthcare in India and innovation in India. Many times it's thought that diluting IPR and therefore limiting innovation will somehow advance access to healthcare, and I don't think that's true. We've already heard from Ambassador Haqqani about the low spend. While, as he mentioned, the spend is only 4.7% of GDP on Indian healthcare, the government spend is even lower, just 1/3 of that. So, in essence, government is spending 1.4% of GDP, which is really abysmal. About a year ago, the Lancet's editor-in-chief said, "I don't see any new policies, any new ideas, any significant public commitment, and most importantly, no financial commitment to the health sector. If Prime Minister Modi does not tackle health, India's economy is not sustainable." And I think this is a pretty scathing indictment. And indeed, let's look at what the promises that were made when Prime Minister Modi took office in summer of 2014. The BJP manifesto certainly talked about insurance for all, health insurance for all. There was talk about certainly reducing out-of-pocket spend. There was assurance of free drug services, free diagnostic services. And we've seen a good deal of disappointment. The plan for universal health assurance sort of went away with the very short-lived first health minister, which was appointed. So, he stayed a few months and with him went this plan. And Ambassador Haqqani referenced the draft national health policy. And we did see a draft, indeed, in the start of 2015. This draft was put out. It included input from several stakeholders, and consultations had been factored in. And of course, they asked for a budget, and they projected a certain spend over the next 5 years. And what we saw was, I'm just quoting from a Reuters report. It said, Prime Minister Modi puts the brakes on this healthcare policy. We didn't hear what somebody's proposing instead. So you can say that, we can't spend this amount, but what is it that we can spend? So it was as if this has been closed down without an alternative. So I would say that, I think these promises at the moment are broken promises. We've got a ways to go. So in the meantime, we do see sort of some quick fixes. Like price capping of drugs or compulsory licensing. And this is sort of seen as, potentially advancing healthcare access for all. So with this in mind, the IMS Institute in India, they did a study to understand what comprises healthcare access. And in fact, much of what Amit has just said is also borne out by their findings. In essence, it was proximity. So today, more than 2/3 of all people in rural India travel more than 5 kilometers. What this means is that they have to take the time off to do that travel. They have to spend the money to do the travel, and they have to forego potentially that day's earnings because they are spending that day in traveling. So proximity was a big thing. And when they reach the end of their travels and reach the facility that they're looking for, the next thing was, the availability, the quality, the functionality of that facility. Are the doctors there? Is the X-ray equipment or the diagnostics working? And, what is the state of that facility? Is it going to make them potentially worse off than when they got there? Right now, just speaking about doctors, I think 75% of all physicians in India are employed in private, sort of in the private sector. They are not at these government facilities that are the cheaper ones. And I think it's at that juncture when a patient reaches there and, after traveling his day, gets there and finds a broken system. I think 85% or more veer away from the public system and have to go to private healthcare. And, then comes in the whole question of affordability, not just in terms of what this costs, but what is the ability to pay. Because with 8% of Indians, that have health insurance, clearly this is not a feasible solution. And also, the out-of-pocket expenses, we've already heard about that, are very high. So all in all, I think, the finding from this Amiee study was, in essence, that one episode of illness which requires inpatient care is it wipes out the monthly average household expenditure, and this is across sections of the Indian public. So I think, I don't want to beleaguer a point too much because this has been said in one way, shape or form, but clearly these are really very serious problems that India has. And I think what emerges constantly is that the biggest barrier to healthcare access is the inability to pay and the lack of financing. And we heard this before. Clearly, the solution has to be a holistic solution. I think several stakeholders have a role to play. It will be the doctors, it will be the hospitals, it will be the pharma companies, it will be the insurers, the NGOs, and of course, the whole effort has to be led by government. So it can't be one single thing. It can't be, okay, let's get these Jan Aushadhi stores working and we are set. Let's cap the price of medicines and we've got a solution. It has to be holistic. It has to, everyone needs to work together. And I heard Amit say that as well, and I can't stress that enough. I'm in total agreement with you, Amit. So I think some work has been done. I mean, I know for a fact that OPPI has worked on a paper and it has been presented to government on potential solutions to healthcare financing, sort of models where private insurance combines with public insurance and how a solution is found. So I think the thinking has been going on, but then we come to the bureaucracy. What happens to this paper which gets delivered to government? Does it get read by anybody? Does it take... The point I'm making is I think the solutions have been suggested and they are there. We don't see any sort of advancement after this paper is delivered to wherever it needs to go. So I think, and in fact, I mentioned the quick fix of sort of price capping, and another study was conducted on the impact of price capping. And sadly, it found that far from increasing access, those that the price control regime has been set up for, the people who really can't afford those medicines are not getting those benefits. So I think clearly that is not a solution that has worked. And so all in all, it is a broken system. And with this conversation, let me move just for a moment to the innovation conversation. And on innovation, I want to quote what the Infosys chief, Narayan Murthy, said at an event at the Indian Institute of Science in Bengaluru, I think a year ago. He said, "No noteworthy invention, technology, or idea from India has been seen in the last 60 years." I think we would all agree in this room that clearly IPR is directly linked to the level of innovation in any country. The protection of intellectual property is something that we need if we are to see innovation. And India has some work to do here. Perhaps it's just a decade ago that we've signed TRIPS, so maybe that is still a culture we are getting accustomed to. Many will say, but a decade, 10 years is a very long time, 11 years actually is a very long time. But think about it. Up until then, all Indian pharmaceutical companies were doing what India called reverse engineering, what much of the world today would be called piracy. But this was legal. This was how the pharma industry functioned. But and today it's the Indian pharma industry who has been very comfortable in their ways, which is very vociferously opposing stronger patent protection. I think one of the challenges that the Indian government has with strengthening IPR is just dealing with the domestic industry in an environment which is nothing if not nationalistic. So I think, I thought, let me just lay this out on the table and, I expect there will be pushback on this because these are strong words. But I think right now the system is sort of leaning towards favoring domestic pharma in India. And there are many, many challenges in the system there. So let me not throw the baby out with the bathwater. I think we've seen some good signs since Prime Minister Modi came in. There have been conversations around IPR, the protection of IPR at the highest levels among the two heads of state. There have been conversations between the ministries of commerce of the US and India, and these are good things. There has been, we've seen the effort put in to emerge with an IPR policy, and I think we'll still need to see how this sort of finally plays out, because the policy is very broad, and then the new IPR policy is very broad, but then how different elements are implemented will need to be seen. I think right now the current reality on the ground in India is that there are many challenges in terms of ambiguity of language, the interpretation of what different elements of the Patent Act mean, as also the very fact, and also this leaning, this constant tendency towards compulsory licensing. We haven't actually seen any new CL in the last several months, but the fact that there is an inter-ministerial committee led by the Ministry of Health, whose only mandate is to be looking for potential targets for compulsory licenses, I think that says something. So it's not just about the letter. I think we need to see this in the intent. And of course, there are other things which I'm sure will be taken up in the subsequent panel, like, the 3D hurdle, which seems to violate a TRIPS requirement, and also is just entirely focused on pharma and other challenges. So I'm going to pause there, Ambassador Haqqani, but forgive me if I've repeated some of the things that you've already said before, but I felt it was important to emphasize.
Absolutely. I mean, there are certain things that emerge from what you've said. Okay, so let's go first to the innovation piece of the conversation. I think there's a consensus, among the three of us at least, that there is a direct connection between the Indian attitude towards intellectual property rights and innovation, and that India would perhaps be better off with clarifying its stance, its position, its application of IPR in India, and that would perhaps help, in addition to, of course, an increase in research and development spending, which is very low right now. And India has to so it's a vision question in some cases. Does India want to remain a nation of followers or of innovators? Does it want to be a nation of reverse engineers? And, very good engineers come out of India sometimes, but basically will they only be good at applying the models and the ideas that others have already invented, and they just know how to sort of keep doing them again and again and producing them. Then, Ranjana, among the points you spoke about was, why has the national health policy kind of withered away? And if it can't be budgeted at the level at which people asked for it, why can't it be at least thought about? And that may actually be connected to the point that Amit made about the Indian bureaucracy. So the Indian bureaucracy usually sees everything as can do, cannot do. More things as cannot do, but basically it's either or. It's not, okay, can we do parts of it over a longer period of time? Now, usually because a secretary in the government serves for 3 years in one position, the way he's looking at it is, it's not going to happen in my 3 years, so therefore, why should I plan ahead? And that's, think in bigger terms. So I think the vision needs to change on that, and maybe Prime Minister Modi can be brought around to understanding and agreeing with that part of it. It's not that difficult. He is somebody who has a broad vision, and he needs to ink in that particular part of it. We could have more discussion on Prime Minister Modi's promises and why none of them have been, but one part of it was, the election promise of free drug services and free diagnostic services. We all know that there is no such thing as free. So somebody would have paid for it. Could the government have paid? Can any government in the world pay for 1 billion people's drugs and diagnostic services? It cannot, and then it has to be a market model. Then what might be a more practical market model? Drug pricing, for example. We all know that the problem with price controls is that you control the prices, and that basically serves as a disincentive for the pharmaceutical industry to invest more in producing the more difficult to produce and more expensive drugs, because after all, the price then is not what would be optimum from their point of view. On the one hand, nobody in the international pharmaceutical sector wants to ignore a market of 1 billion, but is it in a pharmaceutical company's interest to actually invest heavily in a market that fixes prices at a level in which they may not necessarily have the rate of return that they would like? You referred to the broken system, and I think that, again, if I may dig or drill deeper on the broken system, I think the real broken system is essentially an over-regulated economy in which basically a lot of demand exists, but supply has been, shall we say, subjected to so much control that then it makes it difficult for the average Indian to benefit from it. And so I think we have a lot to kind of chew on. I think this may be the right time to open the discussion to the participants. And then towards the end, I'm going to try and bring it to both of you to say, okay, and start thinking now. We've laid out the problem. And I think, with all due respect to everyone in the room, I think many people have laid out the problem many, many times. So governments, we all know, cannot always handle policy change as a package in one go. They usually look for components. Can we do this? Can we do that? So think of 2 things on innovation and 2 things on healthcare for the ending that may be practical and may be doable in the short-term future, say within the next 2 years, both in terms of a legislative agenda for Prime Minister Modi and possibly a practical, pragmatic executive decision agenda as well. So with that, it's open to everybody. Introduce yourselves. If you hold your hand sort of high enough for me to see with my failing eyesight, I will point to one of the young members of the Hudson team to bring the microphone to you. Questions, comments, I would even say speeches as long as they are 1.5 to 2 minutes. Yeah. Yes.
Only because nobody else volunteered, but thank you. My name is John Graham, and I'm with the Health Technology Forum DC and the National Center for Policy Analysis, and I have no experience of India. I'm interested to see that the voters want, I gather from your comments, free drugs, free diagnostics, and stuff like that. But are they not demanding the public health it seems to me, if I was in that situation, I would demand sanitation rather than a lipid-lowering drug for free if the children are dying from diarrhea. So is the democratic impulse getting up there properly to demand the right things from the government, if I'm framing the question right?
Want to be brave enough to try and answer that one?
Okay, I'll have a go. Actually, the Indian Prime Minister has, set a good deal of focus on sanitation and cleanliness and, clean water, making various states open defecation free zones, etc. So I think there is work going on. And I think these free drugs or free sort of diagnostics, it was not so much as I mentioned it not because it was an ask from people, but it was in the manifesto of the government when they came in. And just for a moment, let me, just pausing for a moment of free. Free isn't necessarily free as in, it falls out of the sky. But let me put it this way. Clearly, there has to be robust procurement policies in the states. I say the states because in India, healthcare is a state subject. So each of the states, and some of them are doing a good job. For example, Tamil Nadu, and Amit mentioned a couple others, they have got a robust procurement system where they are able to procure drugs at very low costs because once a company knows that they have to, that there's an assured volume demand, that they don't have to spend money on marketing, that they can even save money on packaging, they are able to procure these drugs at more reasonable prices. So I think, to come back to your question, it will take a little bit of everything, but certainly the government of India is already heavily focused, and the Prime Minister himself is leading the efforts around, sanitation and cleanliness and so on.
And I think there's even an effort to try and, Mr. Grant, there's even an effort at trying to kind of create a new sort of culture because, everybody's talked about how Indians or large numbers of Indians have a tendency to sort of defecate in public or use sort of, don't have a sense of that it's something that has to be done in the loo and not along the road. I think there's a serious effort on that score as well of trying to create a new culture in which people get, so it's like, to put it in the language of late night comedy show hosts, it's like a national potty training program is also in place right now to try and change all of that, and that's all positive. I think that must be appreciated. The young lady there, yeah.
Good afternoon, Professor Misbah Siddiq with the Department of Life Sciences in East Los Angeles Community College. To piggyback off of the gentleman's question, having discussed the idea of complete sanitation, is there a concern, an immediate concern for re-emerging infectious diseases similar to cholera, diphtheria, typhoid, that have opened up in some of the provinces that we do see sort of the waterborne diseases reemerging? And so what is the impact that the Modi administration would like to gather their resources and hone in more of the first responders to sort of get to the major concern of virus-laden diseases?
Sure.
I think, it's a very pertinent question, but the first thing we need to appreciate from a point of view of India is that they're actually looking at this problem in a very deeper way. I can tell you that the project that we are doing with Niti Aayog, and what we are really trying to do now is that we are trying to measure all these issues, and from a very distinct number point of view for all states and districts under the Social Progress Index. And we are trying to create what I call a monthly or a yearly kind of a process wherein we are able to understand what's happening. Having said that, I think these solutions, like when you talk about sanitation or whatever, if I know what is the situation of water or issues of vector-borne diseases and whatever, and if I actually talk about sanitation and how this is really panning out, can I actually compel the private sector to actually invest their CSR budgets as well? So today, for the first time in the context, we are actually looking at it at a district level, or what you would call as a county level, and trying to understand it, and then trying to tell the corporate sector as well to really push out and say that you invest here. Because I think the government also does recognize that all the solutions that we are really looking at cannot just be done by the government. There has to be a combination of social objectives and economic objectives coming together. Because India is such a huge country, like government does not have the money to really do everything and anything. So what you really need to do is that you need to create solutions there, and that is what they're really compelling people. In fact, just a very simple number, the unlocking of amount of money that actually happened because of CSR law was close to about $3.5 billion. That roughly is about 25,000 crore rupees. And if I actually look at 542 districts in the country, and if I invest as a country, and if we invest close to 5 crores in each of the districts, they can actually become open defecation free. So that's the kind of amount that is required. So that means in one single year, if the effort is concentrated enough and it is good, then you can actually make the country open defecation free itself. And I think it's not about potty training also. I think it's about access to those things. I think it's, so it is more about access. Like, so today they have built the toilets and you can actually find that. And if I'm able to do it, I think most of the vector-borne diseases can also be taken care of, because right now it is actually going through the way processes. So I think it is going to be set right. But I think the jury is should be out in the next 5 years. But I think it will happen in the next 5 years, and I'm positively inclined towards it. I think this is for the first time. I feel proud that the government is actually doing something in some relevant part, and doing something which is looks very gross, like it can be what I call part of that fun element, and you can make jokes about it, but it's important that they're doing it.
And in any case, once access is provided, then obviously no one has an excuse. So therefore, basically, access is the main matter.
Absolutely.
Yeah. Especially in smaller towns and villages and stuff like that. Yes.
Denise Leonard, OHSL. About 4 years ago, the IMF did a major paper on fiscal space related to healthcare in emerging markets and in the developed countries. And in the case of countries like India and China, they basically said they could, without any trouble, increase by 4 times their government expenditures or public sector expenditures on health without causing any problems. And the government of India has chosen not to do that. And I think this becomes an advocacy problem and a political will problem as well. With respect to innovation, I think there's lots of innovation going on service provision in the NGOs and in the private sector, but they're not being scaled up. Part of the reason they're not being scaled up is because of lack of funds. Another thing is the division between private and public, and when a large portion of your population can't afford private health care. So my question is, the argument at the macro level of why this country should be focusing on healthcare. Why is, so much money being spent on defense, for example? Once you start educating these people, then if these children start dying, then you've lost your investment in education. There's a whole series of arguments that can be made, not just with respect to the loss in life and dailies, but, that why this is a sound investment for the government to make, at least with respect to the public health side. I think India, no doubt, is going to have a private-public healthcare system. It's not going to be 100% private, but clearly understanding what the public sector is going to do and building that program over a period of time. It's not, other countries have done it, and I just don't see the real strong political will to carve out that money that could easily be found in the budget to do quite a bit.
Yeah. So I think everything that you've said is I have to agree with everything that you've said. To begin with, in terms of the money that is spent, I have to tell you today, the health budget, such as it is, often gets returned at the end of our financial year because it is unspent. So it's not only a question of allocating the budget, it is about the Ministry of Health having the ability and the thought to deploy that allocation. So I think, clearly there is a problem with what to do with it. It's more than just the money. The quick response is it has to be more than just the money. And as far as priority goes, I mean, there are some sectors that have been declared formally as priority sectors. For example, infrastructure, others. Health and education do not enjoy that priority status for some reason. And indeed, the point that needs to be made to the government of India, and we try to do it, and I'm sure others, is that it is not to be seen as an expense that is to be incurred. It is an investment, just as in any other priority sector, an investment to be made. And you mentioned defense and others, so there are many Indians who also have the same questions.
Try and sort of explain to us why allocations that are already made are not utilized. After all, it would seem to me that there should be a demand for the health services. It already exists. So why are ministries of health in the various states as well as at the federal level unable to utilize resources that are already allocated to them, as you pointed out, or at least the budgets that are already allocated? Could it also be a bureaucratic little finagle in which, the resources are allocated but not delivered on time? I mean, I'm familiar with that because I come from civilizational India myself. I mean, Pakistan and Bangladesh may be separate countries, but civilizationally, 5,000 years of being together makes you think a certain way and act a certain way. So that happens a lot. It's part of the budget. It's allocated to you, but it's not available to you at a certain time. So therefore, you don't spend it, and at the end of the year, somebody gets to say it wasn't spent. Is that what's happening there?
Very often that's the case, that by the time the funds are released, it's at the end of the year, and then you're scrambling, and then the budget period is...
We have to have a 10-day conference on how to deal with Indian bureaucracy on its own.
I think, can I answer that?
Yeah, please.
I mean, part of it is the government's budget is going primarily to the public sector, and the public sector is constrained and also inefficient. I mean, this is where the jump in the bureaucracy has to go, that far more funds are available to private sector, both for profit and not for profit, to provide services so that those monies are spent by people who are able to spend them. It means you have to regulate and you have to monitor for quality, because there's been lots of problems with that. But that's also a way of expanding who can actually provide services and making sure that they happen.
Right.
Funding that innovation.
I think this can happen once the money that is being allocated is spent. I think the biggest problem or the burden is from the bureaucratic side, actually, as you say. And why does it happen? I feel bureaucracy is the most incestuous industry in the world from a whole thinking point of view. They just do not have that new thinking. They don't have the vision or whatever. They might like to think that they have vision, but they are the set of people. I always say there is a Ramanujan theorem which says like the sum total of all numbers from 0 to infinity is -1 by 12. That's exactly what happens with Indian bureaucracy. The sum total of their IQ is -1 by 12. So how do you change that? How do you push it forward in terms of making them thinking new and do away with their incestuous ideas? Because they're just talking about the same set of ideas. Look at solutions from a fresher perspective. And I think this is where what you said, we have to actually look at training the bureaucracy in a different way, make that thinking differently. That was a question that was asked, and you do that.
The thinking is essentially we are the custodians of the government, of the state, and we basically need to keep things okay. And innovation is not our responsibility. That's the sub.
Yes,
that's a sum total of the. That's why it's a steel framework.
Yeah.
It's like steel. It cannot be flexible. And that's what it is. Look, we are coming up to kind of time constraints because we have a second panel. So if anybody has a question or a shorter comment, do it right now, and then we'll move on to the second panel. Yes, right here, right in front. So I'll make that the last comment/question, and then we can move on to the second panel. Go ahead.
Hi, I'm Connor Harrington from USTR. Just a quick question for Dr. Kapoor. You mentioned earlier the importance of state-level innovation efforts and IP in particular. I'm just curious if you could explain more, particularly in light of the ambassador's comment about the difference between central and state responsibilities over IPR.
Yeah. So, that's a very important thing. When you talk about, I'll agree with the ambassador that you have to have the overarching IP regime in the system or in the country. But what the states can do is that, like, as all the states have the state investment policy or industrial policy, we can actually look at an IP policy there so that it is enabling or enables the environment to set it right. I think there are 4 states right now which are working on it. And the mandate is that all of the states are actually going to have their own IP policy. And I think it's very important to understand that the government is now saying that each state should understand its own innovation ecosystem and try to build it. So the steps are there in that direction. It is just going to take time for us to really get there. I think the conversations have just now started. And in terms of like really moving an elephant like India, it's going to take about a decade or so. But I think the intention is right, and we are moving into that direction.
So the regulatory framework will still come from the central government, but other incentives for innovation and application of the intellectual property rights in manners in which it would be beneficial would devolve to the state. That's probably what Dr. Kapoor's point. So now the final thing that I had requested both of you, 2 ideas in both respective fields, immediate so that action ideas. What can the Modi government do in the next 2 years in healthcare, in light of what you've already said, and in innovation? Dr. Kapoor first.
I think in innovation, I think they should, one, focus on educational institutions, increase the budget on research, let these people collaborate with the industry. I think that's the biggest thing. The second thing, they're already doing the startup thing. We need to focus on moving from job seeking to job creation behavior. That is there. In terms of healthcare, I would rather think they should be remove market distortions, let more open market solutions come through. Let private sector enterprise come and bring the solutions, because we know that the public sector is burdened and it cannot do it. So start easing out and removing market distortions.
Good.
In terms of innovation, I think the first step is to disband a committee, which is, and this is a very easy thing to do. You disband a committee whose only function in life is to look for potential compulsory licensing of drugs. So I think that's a big one. The other one is sort of, an innovative idea, not necessarily to do with IPR. Narayan Shetty, the chief of Narayan Hridayalaya, Devi Shetty, sorry, he had the one suggested, just in terms of insurance, he said, what if you added 1 rupee, or I don't know, there was a certain amount, a very small amount, 5 rupee to every phone bill every month. Almost everyone has a mobile phone. And he said if this could be treated sort of like an insurance premium, he made a calculation as to how this would be able to support just basic healthcare for everyone.
Kind of a universal healthcare system funded by a 1 rupee cess on everybody's mobile phone.
Yeah, so it's like a premium. And so I think it's worth exploring. The point I want to make is not necessarily the Devi Shetty idea, but to on this idea to see what could be done where people sort of pay, because we don't have a culture of insurance paying. And we clearly know that financing of, out of pocket is a big one, the ability to pay. So this is the 2 ideas I had on innovation. And in terms of just healthcare, I'm going to cheat a little bit and maybe suggest 3 quick things. The first one is, give this sector priority status. It's an easy thing to do. Second thing I would say is review, maybe remove all taxes on drugs. Today, the taxes on drugs are higher than government spend on drugs. This can't make sense. So remove taxes and
so basically, actually, the mechanism for maintaining more affordable drugs would be not to fix prices, but to actually withdraw taxes. That's what you're saying.
Yeah. So that, don't tax this thing. And the third thing was that what about picking up the examples of the good procurement policies, which are really effective in some states, and replicating them in others. And maybe you can do it by way of creating a competition between states where the winner gets some incentive. something like that. Because there are some good models.
Think of that
BioNTech.
incentive is the next step.
Well, really I meant is that use the model which is working well and replicate it.
Okay. Well, I think all in all, a pretty good and interesting discussion. I have to pass the mantle on to the moderator for the next panel. Thank you all for being with us, and don't go because the next panel is about to start, which is going to be on specific initiatives of the private sector within the rubric of innovation in healthcare in India. Thank you very much, Dr. Amit Kapoor and Ranjana Smetacek. Thank you.
And welcome to the second panel, which will address specific initiatives in the field of healthcare and innovation. My name is Jerry Norris. I'm a senior fellow here at the Hudson Institute. We have three very highly qualified panel members this afternoon. The first will be Kevin Walker. Kevin is Executive Director of the Partnership to Fight Chronic Diseases. He is currently a partner at Penn Quarter Partners, a lobbying group based here in Washington, D.C. Before that, he was Managing Director at Global Advocacy Partners and the Vice President of External Affairs at Pharma. He also served in leader positions at Golden Harris and the Paul Worth Associates. Kevin, if you'd like that.
Good morning, and thank you for hosting this event today. I'm going to talk a little bit about the rising costs in healthcare, and in my job, I have the opportunity to travel around the world, and oftentimes, we have problems with the deck. And oftentimes, when we meet with different organizations, whether it be in Mexico or South Africa or Japan, China, India, people talk about what they believe is driving healthcare. And obviously, the issue of cost is on probably the tip of everyone's mind. Prices are too high. Doctors are practicing defensive medicine. Our consumers overuse services. And this takes place here in the United States. This takes place in India. This takes place around the world. But what we know is it's actually the increased prevalence of chronic disease. So you have more people with more diseases around the world. And in the United States, it's about 86 cents of every $1 billion we spend in healthcare is spent managing people with chronic disease. And we projected this out over the next 14 years through 2030. And if you look at the numbers, taking into account productivity, chronic diseases will cost the United States about $45 trillion. That's no different in low and middle income countries. It's the #1 cause of death in these countries. In low and middle income countries, it's about 75% of the deaths with a significant price tag associated with it. When you look at India, it's about 60% of the deaths. It's not they have fewer chronic diseases, they just have more communicable diseases that they're dealing with. And it's a significant cost in this country as well. As you look at what's killing Indians specifically by diseases, cardiovascular disease, far and away the #1 cause of death in India. And for anyone who's been looking at the news lately, respiratory disease is rapidly climbing. With the burning of the crops and the fireworks from Diwali, I think I saw such statistic recently that in places like Delhi, the amount of pollution is 10 to 20 times what WHO standards are. So it's a significant issue. And you might remember a New York Times reporter, Gardner Harris, moved his family to India and I believe stayed there about a year or so and ended up moving back after his children developed respiratory illnesses. So the impact in India is significant. There's a significant societal impact, the cost to society, a significant health impact, again, the #1 cause of death, and a significant economic impact. We talked a little bit about this, the low public spending on healthcare. India ranks among the bottom 5 globally. So my organization is the Partnership to Fight Chronic Disease. We're an organization based here in Washington, D.C. We do operate all over the world. We are an umbrella organization. We're made up of about 120 groups here domestically. That includes everybody from the pharmaceutical industry to the insurance industry to AARP to doctor groups to universities to patient groups across the board. We heard on our last panel about the need to bring everybody together, and that's what we've been trying to do over the past 7 years. Bring all of the stakeholders together to address the number one cause of death in the world. We've replicated this model globally. We've been active in India for about 7 years, quite active in India for about 7 years. In South Africa, we've been engaged working with the government, screening 7 million people in that country for cardiovascular disease and diabetes. In Turkey, in China. Unfortunately, the problems with chronic non-communicable disease exist everywhere in the world. So we heard a little bit about the health policy. About 2 years ago, in a series of meetings with the government, we were asked by the Minister of Health to convene a group of stakeholders to identify some policy recommendations, which we did over the course of about 18 months. They were adopted by the Minister of Health and adopted into the policy that unfortunately has not taken off. Our approach as we moved forward in the country of India was not to do advocacy in India how advocacy is traditionally conducted, but to take a model more of the United States. So how can we liaise and build a dialogue or momentum with the stakeholders impacting the government? How can we work with the government directly, and how can we leverage the media? We've had hundreds and hundreds of pieces in the media to try to get the dialogue around healthcare. As we talk about innovations today, we're more focused on innovations in policy, particularly in India. So as I mentioned, we had 150 experts, and we had some key facets of our health recommendations to the Minister of Health. These might not seem like innovative things to you all, but in a country like India, they can be groundbreaking. Simple things like focus on the patient and not on the disease. They might treat somebody with diabetes, but not treat a patient who has multiple comorbidities. So someone who comes in with cardiovascular disease, diabetes, and mental health issues. How do we focus on treating the whole patient? We heard some about financing. A multi-payer financing system is incredibly important in a country like India. As we heard, they're not going to be able to fund it publicly. We've encountered some unique challenges on advancing these goals. Just level setting what a multi-payer financing system means. From the most elementary level, it was not understood in India. So this is the document that we released in New Delhi last year around this time, to great fanfare, with the government, with WHO, throughout the media. There are key recommendations in here that focus on 3 core areas. I'm sorry you can't see them from here, but they are available at our website, fightchronicdisease.org. They focus on 3 areas: policy and surveillance, strengthening of the healthcare system, and healthcare financing. And so as I wrap up here, where we are now, since there has not been a lot of progress in the National Health Plan, we're working with Niti Aayog, who many of you may know is a government think tank. And they've been charged by the Modi administration to set forth to create a vision document for the country moving forward. And it's to be a 30-year vision document, or at least through 2030. So we're working with a number of other organizations, including Public Health Foundation of India, the World Bank, the Gates Foundation, the WHO, to really lay out a plan for the country moving forward. Again, without continued advocacy, these recommendations will be no different than with the health plan. It will be a document that sits on a shelf somewhere and never gets implemented. We have seen a great deal more interest, a great deal more momentum, a great deal more willingness to be solutions-oriented in India, but there's going to still need to be a lot of coordination among the NGOs and amongst the people in this room to move the ball forward. So with that, I'll turn over that.
Thank you, Kevin. For the past 40 years or so of development assistance from groups like the World Bank and USAID and the World Health Organization, everything was targeted on infectious diseases. And now, according to the World Health Organization, by the year 2020, which is just around the corner, leading killer in the developing world will be cancer. And I wonder if Kevin might have some idea what agencies are doing to gear up to fight, to deal with chronic diseases like cancer.
In India or domestically?
Or all around wherever you're working.
Well, so it's obviously a significant issue in this country that many are trying to raise awareness of, both addressing the issue of cancer and supporting initiatives to focus on the prevention of the disease. One of the primary tenets of our organization is it's going to be a whole heck of a lot less expensive to prevent these diseases than it may be to treat them. But what we can also do is figure out ways to better manage these diseases around the world.
Okay, thanks. Our next speaker, to my left in the middle of the three chairs there, Amiee Aloi, is the Associate Vice President for International Advocacy at Pharma here in Washington. She has previously worked at Avalier Health, a leading healthcare advisory company dedicated to business strategy and public policy, and also contributed to research work at the Institute of Medicine here in Washington, D.C. Amiee, please.
Sure, if you wouldn't mind the clicker, I'll just sit, if you don't mind. I have a few slides. Thank you. Great. So I wanted to talk today about an issue that I think is right in the crosshairs of the topic of conversation today, advancing innovation in healthcare. So I have a little bit of feedback. So an issue that's right at the crosshairs of advancing innovation in healthcare, not a specific initiative, but a larger policy issue. Dramatic pause for introduction, which is clinical trials. So the advancement of clinical trials is a perfect example of how we can advance innovation and healthcare simultaneously. Now, the Indian government has put the life sciences sector as a strategic sector in many of its initiatives and priorities, which it's announced over the last several years. The Make in India initiative includes pharmaceuticals. Startup India includes pharmaceuticals. Digital India includes life sciences, other data issues that are very important to the life sciences industry. And even the national IPR policy, of course, talks about creative India, innovative India. Then the biopharmaceutical industry across the globe spends roughly about $140 billion annually on global research and development. And many people wonder, what does that entail? Where does that money go and what's it spent on? Well, 60% of the R&D spending goes towards clinical trials. It's a huge component of the money that's invested to advance science and bring new medicines to the market. So why are clinical trials such an important component of this? So they're important, of course, for the reason that I think most people understand, which is the advancement of science. Clinical trials are critical to bringing new medicines to market because once we've identified a new compound or a molecule or a protein and we think that it may be effective, you have to test it. You have to make sure that it's safe for people to consume. You have to make sure that it does what we hope and expect it will do. And that is a very well-controlled, very time-intensive process that often involves adherence to international standards and making sure that we understand what we're testing and what the science tells us in the collection of data to understand that. Clinical trials are also extremely important for patients. For a number of patients, this means early access to new medicines. It means access to new treatments, to new medical care, to highly trained professionals, and to learning about their disease and accessing better health care. It's also important, again, for patients because through clinical trials, many times we learn new things that we didn't otherwise know about medicine, such as new indications or other uses or side effects that could be really critical for patients as we bring new medicines to the market. Clinical trials are also really important for economies, and I think this is an interesting component that is less talked about when we talk about the advancement of clinical trials in the science, where when you have clinical trials in a country, in a city, in a local healthcare center, there is an entire industry that surrounds the clinical trial process. It brings in financial inflows to hospitals through infrastructure improvements, payments to doctors, to consultants who are helping to collect data, to run the clinical trials, and an entire industry that is fueled by the process of advancing what we think of usually as a scientific experiment. So there are tremendous benefits there. It also benefits for the government through tax collection. When you have payments that are going, the government benefits through that process, as well as the opportunity for partnerships. Anytime you have a huge effort moving forward, there are often efficiencies, other sets of intelligence and knowledge that you might not have, that you have an opportunity to reach out, find another company, another institute, another medical center to take that forward through the clinical trial process. So what does this look like in India? Currently, India is home to about 16% of the world's population, 20% of the global disease burden. We've heard a lot about that this morning already. Yet only 3% of global R&D spending and less than 2% of global clinical trials. And this, you can see in the chart here that India hosts about 2 clinical trials per million population, which is a scale that is often used to look at these numbers, which is the lowest rate among the BRICS and nearly the bottom of some of the other Asian countries. So I know what you're thinking. I know you're thinking, Amy, India is a huge country. They've got lots of scientists. They've got great hospitals, really smart people. So this seems like it's a strange data point and that this would be much, much higher given we know that the potential that India already has. They also have a very robust pharmaceutical industry. And so some people might often think that these numbers should be much, much higher. I agree. I think these numbers should be much, much higher. And there's a lot of great potential in India to be a leader in the global development of medicines and other life sciences. But unfortunately, over the last few years, there's been a very tumultuous policy environment for clinical trials in India. Making decisions about where to host these clinical trials requires a tremendous amount of predictability. If you're going to bring something that is a scientific process that requires a lot of global compliance, you're trying to sync with other trial sites in other countries, and requires a tremendous amount of money, you want to know that when you bring that trial to a country, that the environment is going to look relatively more or less the same for the number of years that you're going to be conducting that clinical trial. And in India, over the last several years, there's been a lot of policy change in the framework for the approval and conduct of clinical trials. Some good. The Indian government has made a tremendous effort, I think, to bring clarity to some elements of the clinical trial policy framework to provide better protections to patients around the informed consent process, which is good. They've also made some changes to guidelines around how patients are treated if they suffer an adverse event during a clinical trial. And in the process of doing this, they've made other changes, some good, some bad, of course, that have just created a lot of uncertainty. And so I think there's a tremendous opportunity here, and I think here there is a lot of political will moving forward to make the necessary changes to create a predictable and transparent framework around clinical trials in India. If this were to happen, we talked about the tremendous potential that India has, there could be some real amazing benefits that India might realize. An economist did some modeling to look at what the actual benefits would be to India. And if India were to address outstanding concerns with clinical trials regulations, estimates suggest that they could see an increase in the number of new clinical trials per year to above 800. And to give you some perspective, I think last year there were less than 100 clinical trials approved in India. So this is a dramatic increase than where we see right now, given the uncertainty in the framework. And again, if India were to address the outstanding concerns in the policy framework, they could see over $600 million in direct economic and indirect economic gains as a result of clinical trials due to all of the other benefits and surrounding atmospheric and ecosystem changes that you see related to clinical trials. So again, not a specific initiative as some of the panelists have talked about, but a real opportunity to advance innovation in healthcare in India, where I do think that there could be some great improvements in the very short future to see greater life sciences drug development in India. Thanks.
Thank you, Amy. And now on my very far left, we have Jeffrey Hamilton. Jeff is the Senior Director of International Public Affairs at Pfizer Pharmaceuticals. Before that, he served as the Director of U.S. Public Policy at Daiichi Sankyo. He has also served as the Manager of Business Strategy, the Associate Director of Economics and Industrial Policy, and Director of Global Public Policy, and lastly, charge of corporate responsibility at Merck Pharmaceuticals. Jeff?
Thank you. So I'm going to, let's just get my slide here, give a specific Okay. I work in the pharmaceutical business, so we always have slides. That's just the way we do things. Great, thank you. So I'm going to talk about a specific example of what we're doing in India, what Pfizer's doing in India, and hopefully can illustrate some of the opportunities in this space in innovation. So, Pfizer sees India as a powerhouse for healthcare innovation. And, there's been some tremendous opportunities here to advance a culture of an ownership society, or in the culture of property ownership. And with the government working on and understanding the value of innovation and how that can actually advance India's economy and as well as their healthcare system, things like working on the national IPR policy can help accelerate innovation and of course, advance the economy of India. And then it also can translate to helping a specific industry that is very important to the Indian economy, which is the pharmaceutical industry. So we have a specific program called the IIT Delhi Innovation and IP Program, and I will get to that in a second. But first I want to give a little bit of a background on how we got to that. And we're going to, first I'll talk about the CSR provision under Section 135, how we at Pfizer look at corporate social responsibility, and then I'll talk a little bit about IIT Delhi. So in the previous Congress Party government, there was a provision that was passed under Section 135 that actually required all companies of a certain size to spend money on corporate responsibility activities. And so at least 2% of the average net profits made during the 3 preceding financial years was the requirement to actually have companies spend. And this is both multinational corporations as well as Indian companies. So we looked at it and said, okay, what's the impact in Pfizer? And we, in this current fiscal year, we have to spend at least $1.2 million on CSR activities. And last year was about $1 million. So what are those activities? There's a Schedule 7 that says that indicate activities can be undertaken by a company under CSR. So we look at what does Pfizer look at when we do corporate social responsibility. First thing is we want to promote access to quality health care. We want to be partners to the government as well as other stakeholders. We want to nurture innovation, support community involvement by our colleagues and our employees, and create goodwill for Pfizer in India. So when we look at the considerations for our focus areas, some examples are some qualifying activities that we look at under the Schedule 7 are promoting healthcare and sanitation, which has been mentioned before, technology development, disaster relief, women's empowerment, environmental sustainability. And we have our own business priorities. We want to enhance the value of innovation and IP. We want to advance the salience of product portfolio, and we'd like to strengthen our relationship with the government and with healthcare providers. So the government's priorities are preventive medicine, positive health information, public-private coalitions around disease awareness, access to health care, sanitation and health, as we said, and Make in India, which is, of course, a big advancement for the economy. And what we are already doing is we're already doing CME programs. We do advisory boards. We have patient assistant programs. We do capacity building. We do disease awareness. And we thought, well, what can we do that actually lines up with what the government is? And that's these focus areas. One, encourage and support Indian innovation and Indian IP with a focus on healthcare. Undertake awareness and access programs in partnership with the very robust NGO groups in India, as well as a focus on women and children. 3, we want to support national and state programs, priorities with high linkages in healthcare, enlist employees as volunteers, and persist and continue to support national disaster relief. So we decided that we do all those other things and don't have time to get into all those. I'm going to focus on IIT Delhi. And here's the key strategic example. So this program, the Pfizer IIT Innovation IP program, supports healthcare innovations through funding, resources, and expertise and infrastructure that allows innovators to bring their healthcare ideas to the marketplace. We have 2 components. One is to be a way for companies to have an incubation accelerator and be able to work with IIT Delhi, which is a premier institute of technology in India. And they have this organization called FIT, which is the Foundation for Industrial Transfer and Technology. And that part of the program is where the folks that can actually, the students or the entrepreneurs can actually get funding and be able to sit in IIT Delhi and be able to work on their idea to advance healthcare, and then also access the professors at IIT Delhi, as well as Pfizer experts. Then we have a second component where the innovators who already have a proof of concept can look for IP support to actually get their product to get it patented. So the initial unencumbered funding is we have a commitment of up to $80,000 for each innovator to provide innovators with the residencies for up to 2 years at IIT Delhi and support the incubation from the beginning stages through prototyping through go-to-market. And then publish communications, and we have a system where we publish that in the newspapers, et cetera, to reach out to possible entrepreneurs and in many cases the university communities to say, what are your ideas in healthcare? And you can apply for this funding. We've had a tremendous response, and where we show this is that we have unencumbered funding for up to 50 lakhs, which is roughly $80,000. We're going to be doing 4 projects under resident incubation per year, and then 10 projects up for the IP filing services, which are a little more advanced, and they already have the proof of concept on those ideas. So we just launched this about a year ago, and we already had 75 applications from across the country for this phase 1 launch. And we've received quite a bit of visibility among key stakeholders. And in fact, we had Secretary Amitabh Kant, when he was heading DIPP, come and give an opening speech about this program. And he thought it was a great opportunity to advance Startup Stand-Up India as an example. And the nice thing is, since we've now put out the first set of funding, DIPP now has actually done a very specific endorsement of the program where we can actually utilize DIPP's seal of approval, et cetera, on our materials and things like that. So the second phase of the program was launched in September, and where our first initial grants were given out. And so here's 5 examples. 2 of them are in the resident incubation area. One is a program for early diagnosis of typhoid, and it's a portable device, and the patient can actually get the results within 6 hours to find out whether or not they have typhoid. And this is going to be really, really important to advance healthcare in rural and hard-to-reach areas. Second one is a novel wearable device for protection of respiratory hazards. And as we talked about how the pollution problem, this is something that we think was going to really advance as well. The 3 programs for the IP filing support, which had already been advanced, one is a bioactive nanofiber, which is going to be used in orthopedic and craniofacial clinical practices and surgery. The second one is this multi-board upper extremity workstation for patients who are stroke patients and going through rehabilitation. And then the third is a green manufacturing intermediary process. So again, we're working with these folks to get these types of ideas brought to patentability, and then hopefully at one point there will be opportunities for these to become businesses. And Pfizer has no ownership of any of the intellectual property here. It's purely for the individuals and the startup companies that are putting these ideas together. And so here's some great pictures. Here's the group of the endonasal purification device. The second one is the typhoid group. And then these 3 patient pictures are of the under IP support, the bioactive nanofiber, the green manufacturing in the bottom there, and the multi-board. And the nice thing about this program is that not only are we getting these ideas brought to Indian society, but it really is promoting grassroots innovation. And that's the bottom line. And there's a lot of opportunity to advance grassroots innovation, which will actually ultimately, again, weave into the fabric that ownership society, which will in turn, we think, actually help advance the life sciences across the country, which will benefit not only our industry, the multinational pharmaceutical industry, but will also benefit the Indian life sciences industry and ultimately benefit patients. And so Prime Minister Modi, we were able to, this is our Director of Public Affairs, and this really was his brainchild in Pfizer India, and he had an opportunity to showcase this with Prime Minister Modi, who really, really liked it. So we're really pleased with this positive partnership, and we're looking forward to carrying it forward and sustaining it and keeping it going. And I'd be happy to entertain any questions. Thank you.
Thank you, Jeff. The civil society group called Doctors Without Borders has designated India as pharmacy to the developing world. And India currently supplies, just in the area of AIDS, 80% of all the AIDS therapies that are going into Africa. But now with the rise of chronic diseases, how will India respond in terms of the demand in the developing world for chronic disease therapies? Will it do it through compulsory licenses? Will it do it through joint ventures? Maybe Jeff or Amiee could give us some indication how the pharma members will respond to this issue in India.
Sure. I can give one example. So Pfizer does everything we can to bring our innovative medicines to the marketplace in India, and including in chronic diseases, and cancer was one that was mentioned before. So what we have done is we've actually accelerated one of our key cancer products called Ibrance, and it's called Palbase in India. We actually accelerated it to the point where India was in the top 5 countries in the world where we launched this medicine. And in fact, today it was just approved by the European Medicines Agency in Europe. So India brought it to market faster than in Europe. And innovation is one of the ways to bring other health-related resources to the table and to the country. And yet it's very expensive too. And so we also have our older portfolio of medicines in cancer, for example, available at prices that are dramatically lower than some of those innovative. So we have different types of medicines available for across the country. But if there are patients who absolutely can only take the newest, most innovative medicines, we have ways of getting those medicines to patients at either dramatically lower prices through a shared financing process, as well as for free for those who are absolutely destitute. One of the challenges is getting those resources and getting the right diagnosis and treatments. It's getting the physicians to those poor populations. And it's a challenge that we're working on in a project that we've actually called Project ECHO, which is in the breast cancer space, where we're teaming up with the regional cancer centers in 3 select states. One's Madhya Pradesh, one's in Assam, and one is in Telangana, where we're going out to very rural or below poverty districts to actually bring capacity building, awareness of breast cancer, and training of local ASHA workers, and then bringing mammogram machines out to these rural areas to actually do that diagnosis. So it's a multifold problem, and getting the resources out to some of these rural areas that was discussed at the previous panel is a real problem. And so we want to work with the state governments to figure out solutions to how can we make it sustainable? How can the states help get those healthcare solutions out to some of those rural or poor areas?
Okay. Amiee?
So I would just add that, we've talked a lot about the growing burden of disease, of chronic disease, and there's still a fair amount of infectious disease in the world that we need to treat and tend to. And that problem is going to continue to be there with us. And, Jerry, you rightly point out the Indian pharmaceutical industry and the role that they can play there. And I think that there is certainly a huge role and a huge demand that there will be for those products as we across the globe look to treat more and more patients with disease. But I also think, we don't have all of the treatments that we need on the planet right now. Alzheimer's is a huge challenge. We all know somebody who's facing Alzheimer's right now. If anybody's ever known anybody that has had ALS, a huge challenge that there aren't good treatments for right now. And so we have to continue to advance the science and invest in new treatments, better treatments to treat diseases that we're facing today and that we don't have treatments for. And for that, we have to have these two industries work streams, if you will, working together simultaneously. So I don't think it's, a one or the other. I really think that we need to create an ecosystem and a partnership and work together to make sure that we're advancing good, generic, safe, quality medicines to people who need them through healthcare systems that can get medicines to people who need them, and making sure that we're looking for new treatments for people who need them and don't have them. And that requires a supportive environment to do that.
Okay. Well, when India was designated as pharmacy to the developing world, it was principally because of its production of antiretroviral medicines for the developing world. And it became pharmacy to the developing world without once having to use a compulsory license to do so. But currently on chronic diseases in India, one in cancer, one in cardiovascular diseases, Indian firms are producing under government authorization chronic disease therapies, basically infringing on the patents. And while the Indian courts have accepted the cases for adjudication, they allow the companies to continue producing chronic disease therapies in the meantime. So is this maybe, Jeff, is this an indication that the government is going to continue with government authorization instead of trying to encourage companies to do joint ventures with firms that are part of pharma?
So it's a very good question. I would say, actually, the interesting thing is there hasn't been a compulsory license in quite a while. I don't remember the exact time frame. It's been, 2012. Since 2012. So it actually there has been a turnaround. And the new government realizes that compulsory license is not the solution to increasing access to medicine. And that, if anything, it's detrimental to increasing access, because the companies aren't necessarily providing those drugs that they got that compulsory license are at a cost, at a lower cost in India. They're really doing it just for their own commercial enhancement, and it's not actually increasing access. With the government has really made a concerted effort to show and demonstrate that they are committed to intellectual property protection and how that can promote innovation, and at the same time promote the economy in India. And they realize that they have a tremendous base of their own domestic industry, and that, going back to the joint venture opportunities, there are plenty of opportunities to do more joint ventures for companies to bring their innovative medicines and their innovative portfolio to India, maybe for a price that makes sense for India. Mm-hmm. And then also, in the case of Gilead, for example, they licensed out to an Indian pharmaceutical company so they could actually provide one of their more expensive medicines to places like sub-Saharan Africa at a cheaper price. So there are different opportunities to structure deals that make sense, that are win-win-win.
Okay. Let's have a question period. Let's have a question period. There we go, right there, please.
Hi, I'm Rabat. You know me. I was noting in the news fairly recently that the government is floating a proposal actually that would lengthen a certain rule that would, in essence, provide some form of a data exclusivity, a rule that's now at around 4 years, that they would extend it up to 10 years. And I was wondering your thoughts on the motivation behind this and why they might be proposing this at this time.
So my understanding, the root of this issue is what's determined and what the definition of a new drug is in India. So if you bring a new drug to India right now, the current rules say that it's only a new drug for 4 years. But we know that in practice, new medicines that are covered under patents are oftentimes the patent life is much longer than 4 years. And so often this can create challenges in the enforcement of patents that companies have already received from the Indian Patent Office. So they've applied, the Patent Office says, yes, you're deserving of a patent, and they've granted it. But because of this definitional issue, there are some challenges there that can lead to enforcement issues. I don't know the motivation of why this is going through the Technical Advisory Board right now in the Ministry of Health. It's certainly something that's been raised in a number of conversations. But the national IPR policy talks about one, looking for opportunities to strengthen India's intellectual property rules, but also kind of looking at areas where there are ambiguities between different sets of rules in India. And, as we look at the rules, this is certainly one where there's some unpredictability for companies in India, and perhaps an opportunity where there could be a little bit more reliability in the system that's put in place.
Any other questions, please? Back of the room, please.
My name is Libby Wright, and I work for Citizens Against Government Waste. And maybe I should have asked this in the first panel, but I think I can ask it here. Is that there's been a lot of talk about the bureaucracy and just dealing with the bureaucracy. And of course, in the United States, or here in Washington, there are lots of groups like mine, from the left, the right side, many who promote property rights, many who focus in, as we do, on the bureaucracy and sort of call out the waste and try to put pressure on the bureaucracy to change its ways. I'm just curious, and maybe it's just the nature of the difference in our governments. Are there any groups like that are in India that sort of focus on the bureaucracy, or trying to change things, promote property rights, and put pressure on their elected officials to basically change the government and make it work for the people?
So I would just comment on two things. One, you see a lot of this in India come through the court system in the shape of public interest litigation, challenging different rules and whatnot. So it kind of takes different forms from different groups. But interestingly enough, the new national IP policy, as one of its priorities right out the gate in the implementation, has put awareness around the benefits of intellectual property protection, of things like copyright and trademark, as the first pillar and a very significant priority in the implementation. So you're almost seeing kind of the opposite of what you're talking about from the grassroots up, which very much exists, and there are a lot of academics and think tanks and individuals who are very concerned with this issue and working to advance a school of thought around it. But now the government has really embraced the idea of trying to talk about the benefits of intellectual property protection broadly, and take that message out to universities, to various conferences and academic workshops that are happening, to talk about why they've put forward the IP policy and what they hope India will benefit from the implementation of the policy.
And if I could add to that, it's very interesting. In some ways, it's also the opposite too. Is that the government, under this organization, the Niti Aayog, who's this government think tank, is actually looking at ways to cut out some waste. And one example is, and actually put some more free market thinking into it, and that's one is restructuring the National Pharmaceutical Pricing Authority, the NPPA, which is the organization that actually sets price controls for essential medicines. And they're looking to actually do away with that and realize that if there's more of a free market thinking, then you can actually promote more innovation and actually better ways to keep prices lower through competition and through efficiency. So it's interesting that's actually coming from the government, and there are NGOs out there that are actually advocating, no, we want the price controls. And so there's not a lot of free market NGOs out there that I have seen, and I don't know if Amit Kapoor could maybe make a comment on that, but it'd be great if more came out, if they existed and had a voice in this discussion.
Back room, please.
Thank you. John Graham from the National Center for Policy Analysis and the Health Technology Forum, D.C. And my question also has to do with, I think, something Dr. Kapoor mentioned in the first panel. I think this panel could help me understand better. I think he mentioned university and industry cooperation or words to that effect. I mean, do we need a kind of a Bayh-Dole Act in India or something like that?
Yes, actually, that's something that we have encouraged, and in fact, that there was draft legislation of a type of Bayh-Dole Act that existed a couple of years ago, 3 or 4 years ago even, and this is something that we are again looking at and trying to encourage because it would be important because there is innovation happening, and Dr. Kapoor said something about there's not enough innovation coming out of the universities, and maybe because there's not a way or opportunity to create an ownership and create a new company or business out of that.
Yes, of course. I think there are two things here. When you talk about university system and not performing, either there are not enough incentives that actually exist there, and they're very hugely politically motivated at points in time, like the whole university system, how it operates. It seems to be just getting embedded in some kind of thinking, which is probably not focusing on academic output and so on and so forth, and there is no incentive for academic output. But having said that, but then for the Bayh-Dole Act, I think there is a very huge debate that it is going to happen, and there were indications to that effect, and I can certainly tell you that it is going to be looked at very seriously in the next few years itself, or even the next few months. And that is what I learned from Niti Aayog and the work that we are actually doing with them. In terms of, say, the bureaucracy and how it has to be looking at or whatever, there are many initiatives that the government is looking at. NITI is also looking at it. In fact, the other institution that the government actually does collaborate quite strongly is the Vivekananda Foundation, which is actually looking at the whole idea of how to really change the very system. I think there are some steps to it, and I think the days of career bureaucracy are going to be over in India in the next 5 years. In fact, if I have my way, I would say that in fact, recently I actually said that the whole bureaucratic setup is actually anti-competitive, and there is a compelling reason to believe it is anti-competitive. So how do we change that as well? So there is a proposition of that sort as well. So let's see how this whole debate goes, but then this is an ensuing debate, and we should be in a position to change in the next 5-10 years.
Any other questions, please?
Actually, I have more of a comment on the Bayh-Dole legislation idea, and the idea that it's more of a cautionary note about be careful what you ask for. In this case, the Bayh-Dole legislation, that was what they called Bayh-Dole legislation. If you looked at the language, it actually opened up more opportunities for price control and marching of rights. So if we are going to promote the idea of more tech transfer, we need to make sure that we do it with the right spirit, and that is that they are indeed trying to encourage their academic researchers to come up with inventions that are useful in the marketplace.
Okay, thank you. Any further comments? With that, we can conclude panel number 2, with thanks to our panel. Thank you very much.
It's a pleasure and an honor for me to have the acting ambassador of the United States, the Charge d'Affaires of India to the United States, Ambassador Taranjit Singh Sandhu, who is both a dear friend at a personal level and also a friend of the Hudson Institute, a distinguished diplomat who has served in several countries and will soon be India's ambassador to Sri Lanka. So Ambassador Taranjit Singh Sandhu will give us his closing remarks. Thanks.
Ambassador Haqqani, he of course is also he's an expert on Sri Lanka, where I'm going to be going soon. And I know there's Aparna, an eminent panelists and delegates. It's indeed a pleasure to be with all of you at this important conference on advancing innovations and healthcare in India. I'm happy to note that this is the first of the series to be hosted by the Hudson Institute. India is the third largest economy in the world, with the potential to grow larger and more equitable. The 21st century India has a competent knowledge base and technology pool required to provide healthcare to her people. Yet, there are gaps in the healthcare challenges that need to be overcome. India is bubbling with innovators, and its healthcare sector is no exception, as healthcare providers are embracing innovative technologies. These new ideas not only benefit India, but also provide food for thought for other countries. The bottom line for domestic research and development in India is more features for less money for more people. MLM. This is also true for healthcare, as the objective is to leverage MLM to substantially lower healthcare costs with no compromise on quality and service. The access to high quality, reliable and affordable healthcare service is one of the key challenges facing the rural and semi-urban population lying at the base of the pyramid. Realizing this as a social challenge and an economic opportunity, there has been an emergence of healthcare service providers who have entrepreneurial attitude and passion within the scarce resources available to design and implement innovative, cost-effective, reliable, and marketable solutions. These solutions focus on 4 A's: accessibility, affordability, acceptability, and awareness. India has the capacity to become a hub of healthcare innovations. The National Health Policy of 2015 underlines 3 kinds of innovations that can make healthcare better and cheaper: the consumer-focused, the technology-centric, the innovation business models. Consumer-focused is ways consumers buy and use healthcare. The technology-centric is to develop new products and treatments or improve existing medical technologies, and the innovative business models for the horizontal and vertical integration of all healthcare stakeholders for seamless integration. Public sector healthcare in India is inadequate. It accounts for only 22% of the total expenditure on health. India is no exception to the global trend, where non-government players are active in the delivery of healthcare. There are several models in India where the not-for-profit and for-profit sectors have changed the healthcare delivery. The private healthcare industry is valued at 40 billion and is projected to grow to 280 billion by 2020. It is the most dynamic area of Indian economy. India's private sector is home to a pool of healthcare entrepreneurs who have developed inexpensive quality healthcare with local innovations in areas such as cardiology, eye care, maternal and child health, etc., etc. Dr. Reddy's chain of care hospitals developed the Kamal Raju stent. Dr. Shetty's care model, Narayana Hirdalya, a 1,000-bed heart hospital with 26 operation theatres, where about 30 heart surgeries are performed daily, is an example for rural outreach. An angiogram costs $70 and a heart surgery is performed for $1,000. A cost-effective ECG machine with a software that transmits the readings through telephone lines for just $75 are exemplary cases of LMM innovations in the Indian context. Consider the model of Aureolab promoted by Arvind Eye Care System to indigenously produce the intraocular lens importing the same technology that was used to develop intraocular lens in the United States, now available for as low as $10. The quality of lens has been tested extensively. These are models of learning discussed at the Johns Hopkins Bloomberg School of Public Health. You may be aware 21% of Indian households record out-of-pocket health spending. Illness is a common reason for falling into poverty. The poverty headcount in India would have been 3.7% in the absence of out-of-pocket payments for healthcare. Health insurance is another prime area for innovative solutions. Health insurance is coming to India in a big way. India and the United States have a robust cooperation in the field of health sciences. Together, they are committed to find innovative solutions for healthcare in low-resource settings. Rotavac, an indigenous and most cost-effective vaccine co-developed by Department of Biotechnology and National Institute of Allergy and Infectious Diseases under the NIH, has entered world market to save lives of thousands of children each year from rotavirus. Vector-borne diseases like chikungunya, dengue, malaria, Kala-Azar, or Zika are making an alarming comeback all across the globe. Under India-US Vaccine Action Program, the experts from both countries are collaborating to innovate for scalable, cost-effective solutions for universal applicability. National Institute of Research in Tuberculosis at Chennai, a center of excellence which has received support of the US institutions, has infused an innovative managerial systems leading to success of revised National Tuberculosis Control Program. Multi-drug resistant TB is prime focus for the collaborative research at the center. There are about 5 million HIV infected people in India and thousands need antiretrovirus therapy. The incremental innovations by National AIDS Control Organization and UNAIDS has made the cost of antiretroviral therapy cheapest in the world, with first line treatment costing the government about $75. Antiretroviral drugs for all program in India is part of the curriculum at the Harvard School of Public Health. Cancer is emerging as a major disease in India. Under non-communicable diseases, India-US Joint Working Group, AIMS, and NCI under NIH are establishing an 800-bed National Cancer Institute near Delhi. At this institute, 200 beds are dedicated to research in India-specific areas. The innovations put to use at the center will set new standards of cost optimization. Within the health technology sector, medical devices represent a $2 billion industry. India-US program, Stanford India Biomedical Design Program, is encouraging indigenous innovation. Manu Prakash Labs, Stanford, and DBT using origami foldable microscope costing 50 cents for detection of blood-borne diseases is a classic example of frugal innovations. The Department of Science and Technology and National Institute of Biomedical Imaging and Bioengineering under NIH are co-innovating low-cost diagnostics for hypertension and diabetes. India-US Science and Technology Endowment Fund is giving over 20 grants to bring new innovative ideas to the market with a view to promoting health and wellness. Based on the US Health Data Palooza Conference, Indian IT companies have done commendable work to provide state-of-art solutions. For example, Tata Docomo, a mobile service provider, now offers doctor-on-call services for mere 18 cents. For preventive and promotive health, Indian IT sector is developing games around localized themes to promote health awareness and health psychology. The Swasth Slate Health Tablet is an Android-based computer tablet designed to interface an electrocardiogram, a thermometer, and a heart rate sensor in a single device. It was designed in 3 months and produced at a per unit cost of $50. The slate is given to 10,000 health workers in India to use at primary healthcare centers. As India becomes more prosperous, people are becoming less tolerant of inequity and inefficiencies in healthcare. This drives policymakers, technology developers, and the healthcare industry to focus on innovations. Despite the challenges in India's healthcare system, many experts advocate the innovative, affordable solutions for patient-focused quality care in which we learn and share best practices. I again compliment the Hudson Institute for organizing the first annual conference on India, and thank you and wish you a wonderful afternoon.
Thank you, Ambassador Sandhu, for the closing remarks this afternoon. I think we've had a good sort of discussion and thrown out many ideas today. And of course, Ambassador Sandhu has given us a Indian government perspective as well on what are the accomplishments. And we've heard some critique as well of where India could go. This is an ongoing dialogue, and we at Hudson hope to continue to facilitate it and to continue both in Washington and in India. But thank you all for joining us today. Thank you.
Thank you, sir.